Hello, everyone. Welcome to today's webinar with Mingle Health. I'm Charles Howes, the VP of Marketing here. Today, we're diving into the CMS 2022 proposed rule with proposed changes to the quality payment program impacting MIPS and the alternative payment models. Before we get started, just a quick reminder, this webinar is being recorded. Slides and recording will be sent out later this week via email. You may also ask questions throughout the webinar. We're doing our best to save time at the end to get to as many of your questions as possible. If we don't answer them live, we're going to have our team follow up with anything and encourage you to jump on our website and use our live chat to reach out to us as well. I want to go ahead into the next slide, please.
Oh.
For those of you who are new to Mingle Health, just a quick introduction. We have been a qualified registry since 2012, and our mission is to help you succeed in the practice and business of medicine. We want to be your trusted partner in the transition to value-based care, helping you improve what matters, driving you to achieve efficiency, improve outcomes, and really improve your bottom line. We are trusted by over 100,000 providers since 2012, and would love to help you and speak with you about your needs with MIPS, value-based care, primary care first, all these programs that really are part of this transition away from fee-for-service. One thing of note is that we are proud of our reputation for a unique combination of technology and expertise, helping each of our clients navigate compliance changes, measures, data, your systems, whatever you need along this transition. So please do reach out if you're looking for a MIPS partner or a partner for any of your quality management needs. With that, I'm proud to introduce you to our presenter today. Dr. Dan Mingle is Executive Chairman and founder of Mingle Health. He has decades of experience with quality reporting, and his own experience as a physician in a family practice, his own family medicine practice, led him on a lifelong quest to improve healthcare and help practices of all sizes succeed with value-based care. Dr. Mingle, over to you.
Thanks, Charles, and good morning or good afternoon, everybody. Welcome. Missed you. Hope you're doing well through the crank down of the pandemic. At least I hope so. We won't get too much into that. I'm here today to help guide you through the new provisions in the proposed rule for 2022. We'll go over some timeline issues, how COVID-19 is affecting it, the impact to MIPS in a variety of ways, impact APMs and ACOs. With the highlights, there's some very interesting things in this set of rules. One, the transitional period is coming to an end. This is the last year of the transition rules, and we are going into what is called mature MIPS as of 2022, or Medicare just coined the term in this proposed rule, traditional MIPS, paving the way for a new MIPS after that, which I think is one of the most astounding parts of the rule. Web interface, instead of killing that in the 2022 years, they've proposed to keep it in place for another year or two, depending on whether you're a MIPS group using it to bridge your multiple systems, or whether you're an ACO group that's doing it because that's your required reporting method. MVPs are ready to roll. So the rules are all made. The specifications are out there. There's 7 MVPs to bring live, but they're taking another year to prepare you for it. So propose to bring those out in the following year, 2023. a forecast to end traditional MIPS and go into the next version of MIPS forecast for 2027. One of the things they're asking for is your feedback on that. And MIPS version 2 to be heavily into the MVPs with mandatory subgroup reporting. So let's get into the details.
As we're pulling up the details here, we do have a quick poll. We just want to gauge from all of you is how you're currently participating in the quality payment program. So let's take about 30 seconds here just to get a quick snap poll and understand, which will help us as we're going through the presentation here. All right, about 10 more seconds. Thank you, everyone. All right. Very good. Thank you so much. Not surprising, we've got a lot of folks participating in MIPS, several of you in APMs, and some of you, tuning in to stay abreast to what's coming or guiding your clients and your partners. So let's go ahead and dive in. Thank you all.
All right, thank you, Charles. Now, before I get into the meat, I just want to introduce you to a couple resources. Again, the proposed rule is all about getting your comments to Medicare. Medicare does listen to them. So my plan is to alert you to some things that are coming, to hit on them briefly. I would suggest there's some great resources available. I'm impressed with how Medicare has been improving their resources over time. One, we've got the Federal Register, which where the final rule is published. This is also my favorite spot to submit a formal comment. Clicking into this makes it fairly easy, and you can download a PDF version of the full rule here. On the QPP website, qpp.cms.gov, I like these three resources they've given here. If you're in the resource library on the QPP website, go to the proposed rule resources. It gives you a zip file, and those zip files are here. One of them, proposed rules. I'd suggest if you're planning to make comments, sit with this open, look through the 21 pages that summarizes the 1,700 pages in the proposed rule document, and start from there. There's another resource which just outlines the specifics of the MVP program, although doesn't go into any of the specifics of the MVP of the 7 that they propose to bring live. There's also an executive summary of the QPP rule of the new rules as they are proposed to apply to QPP, and then of course in the proposed rule itself, if you leave to the end, you can come to a variety of appendices, which includes the proposed new and changes to measures and to the 7 MVPs, the details of those. So all of that available there. Now, I think we'll start by just looking at timeline. Of course, you remember those good old days prior to signing of MACRA into the law, where we, maybe not such good old days, but we are here in mid-2021 in the midst of the quality payment program, which of course you remember is made of the alternative payment models and merit-based incentive payment system, with a merit-based incentive payment system designed to train people and move them toward alternative payment models. The most common, the biggest program is various wings of the Medicare Shared Savings Program, which got its start before the quality payment program, and of course there's many others now as well. Transitional MIPS is ending at the end of this year. By law, Medicare has to bring a lot of their numbers, a lot of their techniques up to what's required by legislation. and we're entering what they're now calling the traditional MIPS period, or they've also called it the mature MIPS period. I am calling it MIPS version 1.x. In this time frame, as kind of foundational to this whole movement ahead, is the intention to make quality measures fully digital. And I bring that up because that's behind this this change to the APP. I think it's a little overly bold to think that it can happen by 2025, but this is for intents, not necessarily reality. That now, and also setting in sand this intention to sunset traditional mature MIPS or mature MIPS after the 2027 year. Again, this is set in sand. It's there for your comment. And with some kind of MIPS version 2.0 occurring after that. And that MIPS, we're building toward that with the MVPs, which in this time they're intending to have voluntary with MVPs and subgroup reporting in those MVPs. And when we get there, to turn MVPs and subgroups mandatory. So that's particularly going to affect the multi-specialty groups out there in the academic medical centers. If you're a single specialty group, if you're a solo practitioner, you'll choose an MVP, but you'll do it as a practice or as an individual. If you're multi-specialty, you might be looking at multiple submissions to make those to make that work. COVID-19 still in the rules. Like 2021, they're wondering whether they'll get enough enough submissions for 2020 to build benchmarks for 2022. Our experience is that they will, at least what we've seen from your 2020 submissions, it didn't seem to reduce participation enough to change things. They're also proposing a new COVID-19 immunization measure, looking for feedback on that. I'll give you some more details later. They're proposing to bring the final group of credentials live in 2022, certified nurse midwives and clinical social workers with a policy of automatically reweighting, promoting interoperability for the clinical social workers and providing for them a new specialty measure set. I think certified midwives will, they won't be automatically reweighted, but can apply for it. And for the most part, will work off of similar measures to the OBGYNs. MIPS scoring, let's talk about what's coming there. The mature weight on the various levels, quality at 30%, cost at 30%, improvement activities at 15%, and promoting interoperability at 25%. And the bar charts to the right show you how those have changed over the years of transitional MIPS. The inflection points in that graph mapping final scores to adjustment factors, the biggest numbers are that 75 performance threshold. That's where the score line crosses 0. That's the mean. Or the median. I think they've chosen the median actually for the to go forward, and basing it on the median scores in 2017. The CMS is required, or the secretary is required to make an update to set the method now and make an update every 3 years to reset that threshold for performance and for additional performance. Now, additional performance is where distribution of the extra 500 million they put in for the exceptional performance bonus, that is scheduled to lapse at the end of the 2022 year. So unless it's renewed by Congress, it should disappear from this graph after that. Although I didn't see them talk about that at all in the proposed rule, so I wonder if it's in the works to make an extension on that. So the table at the left show how those inflection points have changed over years. The graph at the right is their current rendition of what it might look like. I think the big things to take from this graph is, of course, there's always been some big losers who don't participate way off to the left, or who participate and get terrible scores. But if this does reach its maturity, and they're going to help that along by removing some of the bonuses, things like that, so your score will more reasonably reflect the differences that they're seeing between, at least in the measurements they're seeing between practices. There could be, you're more likely to be in the losing side. 50% of you should end up there, and feeding a bigger gain on the right. So you'll see, and we haven't seen these predictions since they first came out with this program. They have a predicted score that delivers up to a 14% positive adjustment to those at the highest end of the scale, and of course the 9% peak loss at the lowest end of the scale. So with an updated scoring hierarchy, just to reflect some new methods that are coming out, and underscoring that as a MIPS participant, you can submit, or other people will be submitting for you, potentially from multiple directions, and their intention is to give you the benefit of the best score that hits the books for you. Unless you're a virtual group submitter, in which case you always get the virtual group score, and nothing if the virtual group does not submit. Again, I mentioned bonuses. They're proposing specifically an end to the extra high priority measures bonus, an end to the end-to-end electronic reporting bonus. Now these, of course, will be there for the 2020 year and disappear then in the 2022 year. And I told you about that exceptional performance bonus by legislation is scheduled to end after the 2022 year. They plan to continue with the quality improvement bonus. So if you improve your quality score year to year, you can still expect to see a bonus there. They're still giving that a 30-point floor. So if you score less than 30, you still only get the bonus for the difference between the 30-point floor and your new score. They plan to continue the small practice bonus, and last year for COVID, they increased or for this current year, the 2021 year, they increased the complex patient bonus, and looks like they might be planning to continue that indefinitely and break it up into two components: 5 points for medical complexity based on the HCC code, 5 points for social complexity based on dual eligibility, with a 10-point cap on the two of those. And they're predicting about 60% of submitters will be eligible for one or both of those bonuses. They propose to end the 3-point floor on quality measures. What they've been saying up until 2022 is if you submit, you get at least 3 points. But they're planning to break us all into that 0 to 10 points on each measure in the class 1 measures, which have a benchmark and meet case minimums. If a measure doesn't have a benchmark or does not meet case minimums, which typically is 20 cases, you get no points for it, although they propose to continue giving small practices 3 points. And class 3 measures, which do not meet completeness criteria, again, those points disappeared a year or two ago. Although I think I'm reading it that they expect to continue to give 3 points to small practices for these, but I'll dig into that more specifically when the final rule comes out, which will set that in concrete. And they're proposing a new class of measures to put new measures into class 4, and in the first 2 years of a new measure, give it 5 points as a floor, so you can't score less than 5. And that'll get rid of a lot of the benchmark issues. Those are the most likely measures to not have a benchmark, so those will give you a 5-point floor if they don't have a benchmark. They also, considering that removal of the benchmark protection, they're being a little bit more aggressive at finding a benchmark and proposing that they'll keep looking at the 2 years prior to this submission year to the benchmarks developed there. If they don't work, they'll develop a performance benchmark in the year of submission. And if they can't do that, they'll look at a year prior to that first year. And if they can't do that, then there's no points for the measure. I've talked about a few things they're doing for small practices, brought them all together in this slide. They plan to start automatic reweighting of promoting interoperability for small practices. Observing that a lot of people aren't submitting, but are also not asking for an exception. So they're doing that automatically, and if those small practices make a submission, then they score it. They're giving some different redistribution formulas for small practices, dividing those points a little bit more. They again planning to continue the small practice bonus and the continuation of the 3-point floor. They have been, and I hadn't caught this when they first came out with it, but they have been taking claim submissions and calculating both ways as individuals and groups. And you can only use claim submissions if you're a group of 15 or fewer providers. So, and then giving the best score that came out of that group or individual submission. Now they found some complications in that, some confusion that grew out of that, and they proposed starting in 2022 to make small practices declare themselves, saying that by making a group submission for PI or IA, it will declare yourself as a group submitter. And if you don't do a group submission for one of those, they'll assume you're an individual submitter and score it likewise. So a little on the quality performance category, data completeness criteria proposed to stay at the current 70%. For 2021 and 2022, and go up to 80% in 2023. And though it's not going to affect next year, they propose to set that into the rules with this final rule. And also continue at all patients, all payers, and part of their intention with this move to the APP is to get web interface users into all patients, all payers by making them leave the web interface. The proposed set of MIPS quality measures for the year, and again, you can find that in the appendix of the proposed rule, includes 195 MIPS quality measures. They're putting out a request for information for a COVID-19 vaccination measure, which is essentially what percentage of patients were either given or reported having had the COVID-19 vaccine. And they're also proposing 5 new measures, including 2 new administrative claims measures. Again, those are measures that they can calculate based on claims. And a proposal to remove 19 measures, substantive changes to 84 quality measures. They're also in this rule defining substantive changes and telling us now in the future they don't plan to share with you those non-substantive changes before in the proposed rule, and that they can happen anytime during the year. Which in some ways creates a little confusion. Usually they're minor, they don't mean anything to the interpretation, but they can be important in the details. Our plan will be to continue to keep our clients updated with those as we discover them, and we typically do discover those things. We're monitoring their announcement channel. There are some already outcome-based administrative claims measures. You're more likely to come across these in the MVPs. It's like the one proposed for one of the ones proposed for 2022, which is a risk standardized acute unplanned cardiovascular-related admission rate for patients with heart failure. You can read that. So if you choose it as a measure to count for one of your 4 required MVP quality measures. Now, the implication here is that you can choose a measure that they calculate for you for some of those MVP measures, or potentially for all of them. But if it ends up without a benchmark or below the case minimum, you're at risk there that you won't have 4 measures and you'd get a 0 score for that. The cure for that is to submit more than 4 measures to be sure you have enough, or if your historical performance has been well above the case minimums and there's already a benchmark, then you don't have much to be concerned about there. They're going to be introducing chronic condition measures, mostly in the end, I would say exclusively in the MVP. We'll see them both as quality measures and as cost measures, and they're defining some rules and some what expectations there. They'll stratify patient populations into an episode subgroup, and an episode for these patients is a year of care. There's typically a trigger service related to an E&M code and a appropriate diagnosis, and then a verifying code that within a short period of time that you see the patient again for a pertinent visit that puts them on in your patient list for a year. And multiple providers can have these patients on their chronic conditions list for a year. And then they track your quality of care and or cost of care during that episode of that 1 year long episode of treatment. And of course, that 1 year keeps getting extended as new confirming codes hit the books. All right, a moment on the cost performance category. 5 new episode-based cost measures being introduced. 2 procedural, 1 acute inpatient for sepsis, and 2 chronic conditions. So we're seeing already those chronic conditions episodes coming live. So you can expect to see these automatically calculated for you if they are approved for the 2022 year, starting with that year's program. Improvement activities, 7 new activities, 3 of which are relating to health equity, proposed, 15 activities modified, 11 of those address health equities. I bring this up because you might also call this the health equity proposed rule. They're asking for information about how to address health equity and starting to do some things there, particularly in the improvement activities, but they're also looking for input on how they might structure quality measures and potentially cost measures to show how we're addressing health equities. Removal of 6 activities and expanding the language to accommodate subgroups. They'll be putting some of these established improvement activities into subgroups for MVP use, and they'll be creating some more for MVP use as they expand the menu. I mentioned they're seeking proposals for health equity. A few more changes in promoting interoperability. Here's the proposed measures list for 2022. E-prescribing still there, a query of PDMP to remain by attestation and based on a bonus, but they're predicting that they're seeing a date where they can make that required and based on a measurement. Particularly, there's progress toward a nationwide network that connects EHRs to every state PDDMP, and they've had some successes in testing that, and we may see that live within the next several years. The health information exchange measures unchanged with the new bidirectional exchange measure that came live for 2021. A few new clarifications for the patients getting electronic access. And the rearrangement of the public health and clinical data exchange measures. Now they're requiring either that you or they're proposing to require the implementation or an exception for each of the two: immunization registry reporting and electronic case reporting. And then offering the others as 5-point bonuses, a total of 5-point bonuses for any one or combination of those other optional measures. So the immunization registry reporting, electronic case reporting. I mentioned the ECR now, which will connect all EHRs to the state PDMP recipes or infrastructure. I think I'm going to just take a sip and a deep breath. Moving on. So again, repeating that for both of those public health registries, either implement them or submit a valid exclusion. And if you do have an exclusion on both, then those points will be redistributed. Otherwise, you don't get any points at all for promoting interoperability. Oh, and in the provide patients with electronic access to the health information measure, the 3 important clarifications as they're proposing to modify that information has to be available indefinitely. So once you provide it to the patient, it should always be there, not lapsing. Then to include all data since January 1st, 2016. No details yet, and we might need to be asking for this in our comments. No details on what happens if you've changed EHRs. It would look at this point that's you need to have archive data available in your portal back to the January 1st, 2016 beginning date. They've published a set of 9 safer guides for safety of health information systems, and proposed to require your self-assessment using the high priority practices guide for every year as part of your promoting interoperability plan. The other 8 are there for your perusal and use, but only requiring that high priority practices guide. So altogether, it gives 6 measures in promoting interoperability that look to be ongoing, required for getting any score. And so if you fail on any one of these, then you don't get a score at all for promoting interoperability. So there's a security risk analysis, that one safer guide, the information blocking attestation, which are simplifying for 2022 because ONC now has some civil and monetary penalties for some of the things that were being attested to. They don't want to have the redundant address of that issue. They provide patients access to their health information and the public health and clinical data exchange and in e-prescribing. Failure at any of those without exclusions, which are available on 2 of them, invalidates any promoting interoperability score. All right, to MIPS value pathways. Big, up until now, they've been teasing us with us, talking about it, just year by year, increasing their criteria for how these will be built, how they'll collect input. Now there's finally 7 built and ready to go. So the only thing preventing them going live is their expectation that you've been properly prepared for it. So they're saying proposing these to go live with a 2023 performance year, and they're covering these 7 topics. So if you're a specialist dealing with one of these 7 topics, or a primary care doctor in many cases, you can use these. The specifications look like this. You can see these specifications at the end of the proposed rule. Let's just focus on this page to show you what those look like. It starts with a title, which in this case is the optimizing chronic disease management. There's a set of quality measures. There's happens to be 9 measures in this set. You have to choose any 4 of those. You can submit more than 4 if you wish, and they'll give you the best score out of those 4. It's wise in many cases to do that. There's a set, in this case, 12 performance improvement activities. You choose either one high ranked activity or 2 medium. In this case, there's one single cost measure. Medicare will calculate that cost measure for every user of this particular MVP. There can be multiple cost measures. And again, there's no choice there. They just calculate them as they're appropriate. Now this is what they're calling the foundational level. Below that gray line, one is population health measures. Everybody has, I think it's at least one of those population health measures, and also everyone is liable for the promoting interoperability, which the group score, not the subgroup score, is what's used here. A little bit of uncertainty about whether that's submitted by the group or has to be submitted as well by the subgroup, but the measurements, it's the same measurement that goes with the subgroups as the group. You can, in the first 2 years, they're proposing to be able to participate in the MVP as an individual doctor or clinician, as a single specialty group, as a whole group in the multi-specialty groups. So the implication here is that in 2023, a large multi-specialty group or academic medical center could choose any one of the MVPs to count for everybody, like they've been able to use population health and primary care measures in years so far. They're also able, they're asking vendors or demanding of vendors that we be ready, and we are ready to submit subgroups. So whenever you're ready to do it, we're ready to break you into subgroups. Subgroups, you can submit multiple MVPs as multiple subgroups within a multi-specialty group. APM entities that are assessed on MVPs can start using them in 2023 by the proposal. From 2025 onward, they plan to eliminate that possibility that multi-specialty groups do that alone, but otherwise no change to the potential participants. So far, they're don't have plans to include voluntary reporters, opt-in reporters, or virtual groups in any of these. I'm going to comment on what I think is some advantages to virtual groups to being able to do these, but again, that's not in the rules or considered so far. So again, subgroups voluntary in the first 2 years, actually voluntary for the first, 6 years, and proposed to be required thereafter. Valid even for a single MIPS eligible clinician, and the subgroup would inherit the group level characteristics, including the low volume status, hospital and facility-based reporting, non-patient facing, or excluded from PI. There's a registry requirement they're anticipating. They need to prep for the cost measures, so they're requiring the registration between April 1st and November 30th of the applicable year. If CAHPS is required in the MVP, you need to register that by June 30th. Again, so this is to prepare patient lists, and you register as the group that's going, or subgroup that's going to use it. Identify the doctors who will be using it, or the clinicians who will be using it. Supply a plain language name for the group, you'll get a unique subgroup identifier from CMS, and you'll make whatever selections you want to make or that are optional in the MVP at the time of registration, and be able to change any of those by the registration end date of November 30th is the recommendation. APM performance pathways designed with the infrastructure of MVPs in mind. So it is, if you might say, the first MVP to come live. It is already live. It's operational in 2021. And if you're in an ACO that's required to use a web interface, you are now going to be using the APP. Your option is whether or not you embrace the three measures, registry or EHR, that are in the APP, or whether you continue to use the web interface. If you're a MIPS group using the web interface, you can continue to use it by this proposal for 2022. Then in 2023, you have to switch out of the web interface and be in regular MIPS. It looks like you can choose to use the APP if you wish to, and you can start that right away if you wish to. If you're an ACO, if you're an APM, you can continue again using web interface as your only method of quality measure submission for 2022. And in 2023, you're required to do at least one of the three measures from an EHR or registry, and then the year after that, you have to be off the web interface. At least that's the current proposal. They did leave the window open that they might, if you overwhelmingly demand it, they might put it off even longer. And the rationale is, NACO shared with them that multiple EHRs is the norm, multiple TINs is the norm, so those are the reasons there. To prepare for that is the reasons they're letting this go longer. Now, I'd like to point out that our system is designed to do this. We designed a system in 2012 to bring data from multiple EHRs and multiple practice management systems together into a single submission. It's our standard operating procedure at our standard price, and it doesn't require any special time, doesn't prolong the implementation time. So we're ready to do this for you whenever you're ready to tackle the APP. So here's Medicare wants to give a benefit to people who are using the APP earlier. So they're proposing a benefit in the quality thresholds, that if you hang on to the last minute, you still have the usual scoring protocol that you have to reach the 30th percentile in quality for each measure to hit that quality threshold that you can get your maximum shared savings or prevent you from losing the maximum shared losses. They propose to bring that up for everyone to the 40th percentile by 2024. Now, if you're using the APP earlier, the break is that you only required to hit the 30th percentile for one measure. And if you hit that with one measure, then you're eligible for your maximum shared savings and avoid the maximum shared losses. CAHPS changes a little bit in the APP. The big change is that they're really eliminating CAHPS for ACOs and standardize everything on CAHPS for MIPS. So there's one set of rules. This was not so much in the measures themselves, but how they were scored is a difference between the two programs. So now scoring is going to be precisely the same as in MIPS. ACOs using the CAHPS measure it will collapse into one score as if it were one measure. They propose to start scoring. They've been using these two questions, health status and functional status and access to specialists. They've been using but not scoring them. They propose to start scoring the access to specialist measure. It's become more reliable in the last couple of years because of other changes. And with a little bit time to go, I'm to the end of the deck and the big highlights I wanted to alert you to. So we are open for questions. And while you are thinking about that, I'm going to first take a breath. And then we do have some pre-submitted questions we'll hit as well. Now, it looks like I have something, if I can make it visible. There we go. Jennifer asks, welcome, Jennifer. Always great to get a question from you. Can an example be provided of what a multi-specialty group and subgroup, I'm not seeing the whole question. Let's see if I can make this bigger. Would look like. Okay. Well, multi-specialty group, of course, is anyone who a group Medicare considers to be tied together by a single tax ID number. So we have a number of academic medical centers or even other large integrated networks that are buying practices and keeping the TINs the same. So they grow a number of TINs. That's a TIN defines a group. If that's a single specialty within that group, or typically 75% of the providers share the same specialty or specialty grouping, they're a single specialty group. If that's not the case, even if there's just two, it could be family physicians and OBGYNs together. That's a two specialty group. That's a multi-specialty group. Now, when you break those into their subgroups, we certainly have academic medical centers that would have a cardiology group, a dermatology group, an anesthesiology group. Grouping those all together, those are the subgroups. Now, those groups have been able to submit under one set of measures ever since the beginning of group submissions in PQRS. It was back in 2013. So this means that they will have to be judged on their own on measures that are pertinent to them. The final rule is decided. Well, there's 60 days to submit comments. Then they go. They'll be analyzing the comments as they come in, and then they have some time after that to put it together in a final rule. The final rule is required to be out November 1st. Let's see. Danielle asks, where does the maximum gain estimate come from on your performance performance threshold slide? Well, the performance threshold slide is taken directly from the proposed rule and comes from Medicare. In years past, it has actually represented an estimation, their expectation of what the distribution is going to look like. I expect it still does, but the language around it is a lot more, this is an example. So I don't think they have confidence that that's how it's going to turn out, but it's interesting that there's an intention. And it is, even though we're in a plus or minus 9% year, you saw that peak was at 14%. And that comes from two issues, that they expect more money to be lost on the left side of the performance threshold, or more people to lose money, and to have more to distribute between a smaller number of users on the right side of the chart. So the share could end up being more than 9%. Plus, there's still the $500 million that they're throwing in for an exceptional performance bonus, so that expands a little bit. And if you recall, this legislation is revenue neutral. So they have to, they can only distribute what they collect, except for that 500 million in bonus. They can only they have to distribute what they collect. So in these years with the transition rules, when they're not collecting very much, they don't have that much to distribute. So they are predicting there's going to be bigger losses to distribute in that proposal. Shelley asks, for APMs, the CAHPS is required, right? CMS just updated to one standard survey that is labeled MIPS CAHPS and removed the ACO CAHPS survey questionnaire. Correct. Yes, that's correct. Now, I don't know for certain. I'm not intimately familiar with every APM, but it may not be the case that every APM has to do the CAHPS. I'm pretty sure it's not the case. MSSPs. Again, there's a plethora of options now under the MSSP. I believe that every one of them is required to do CAHPS. And this change is not that you don't have to do CAHPS anymore, but they no longer break it into CAHPS for ACOs and CAHPS for MIPS. It's one single survey that they're calling CAHPS for MIPS. That's really what's changed. There's if you're watching the scoring protocols, there's differences in that. I think the biggest difference is exactly how they integrate with your other scores. And in the new model, which is modeled after how they've been doing it in MIPS, that the 10, I think it's 10 measures in the CAHPS survey collapse. One of those measures will not be scored, but 9 more will collapse into a single score that will act as one quality measure. Anne Marie says, are LCSWs required to report for the mental health specialty? Well, no one is required to report for any specialty. They can only report for those that they have eligibility for, and that is by having patients with the CBT and ICD-10 codes that define the specifications in the age range and other things. So if your patient hits the specifications, you can submit the measure. Medicare wants you to submit things that you care about, things that you're doing, and not submit things that are out of your control. But again, that's a want, not a requirement. And I believe now, I haven't looked at the specifics of the new measure sets, but Medicare is confident now that LCSWs have measures that apply to them. And I believe there's a clinical social worker specialty measure set that they can go to that's not necessarily the same as that mental health set that you are quoting. But since you're interested, you should look at the appendix of the proposed rule. All of the old and new specialty measure sets, anything that's changed or added in the specialty measures are detailed there. Debbie asks, what type of medical records will be required to have available to patients? Office visits, testing, your analysis. The typical data that comes through a patient portal is results. Wow, is there much of anything else? They often have appointments, some of the post-appointments, document distribution. There can be vaccination history, problem lists, medication lists, but that's not always available. So predominantly results, and with those being required to be available long-term. Oops, I lost the question. Oh, maybe I can get it back. there is discussion, and even in this proposed rule, they're talking about the Open Notes initiative and the possibility of requiring that Office notes appear in the display, but that is not an action that's proposed in this rule. Just some consideration. So you may want, if you have strong feelings one way or the other about that, you may want to comment on it here. All right, so next question. Janice asks, regarding the patient electronic access measure, you stated we have to provide historical information back through 2016. We're bringing on new practices with various EHR systems, and this isn't possible in the majority of cases when they switch over to our EHR. That devil, Janice, is going to be in the detail and might warrant your taking the time to make a comment. This is the issue. They are considering the issue, but again, the weight of the comments will help decide how this is going to be handled. If they're going to be really strict with that, that really demands you have some kind of an archive for that new material. I suspect imagining the wide range of circumstances that are out there, that part of that may be covered by the unusual circumstances exception application. So again, we'll have to watch that carefully. It may be the best outcome, and we'll know more in the final rule. The best outcome is going to be that what's available now is your best effort to go back to 2016, and then anything that's there is never pulled back. Dawn asks, is this the last year to use claims reporting? We use G codes when submitting claims. Dawn, claims was queued to go away maybe 6 years ago, and it's still going strong. And there's, well, hardly strong. It's down to about 15,000 users nationwide out of about 100 million, or not 100, out of 1 million eligible MIPS eligible providers. But they're still behind it. They're still using it. Only groups of 15 or fewer providers can use claims reporting. And no sign that it's going to go away. In fact, it has the political benefit of benefiting small practices, which continues to be a hot button at the federal level. Can you please verify, asked Janice, that there's no exceptional performance bonus starting in 2022? If so, what is the pertinence of the 86 point threshold for 2023-4? No, that's a bit of a misunderstanding. I apologize for that. 2022 is the last year that the original legislation makes the exceptional performance bonus available. So that's why it requires an 86 threshold for the 2022 year. I'm expecting it to go away, but again, since Medicare didn't mention it at all, I wonder if there's plans in the works to renew that. But it is still there for 2022, and yes, there is a threshold at which it will be provided. Jim asks if MVPs will become mandatory eventually, and CEHRT is a prerequisite, why will small practices be automatically exempt from PI? Won't that set small practices up for failure of MPVs or MVPs? You have a point, Jim, but I think Medicare does want to see small practices on EHRs, on CEHRT. And I think that's going to be a moving target for every final rule, and certainly, therefore, every proposed rule. For right now, and I think you can be only confident that continues for another year, at some point they'll say, it's time, guys, it's time to play. But until then, I think you can see that that policy follow through even into the MVPs. Yes, it's generally required, but again, the small practice exclusion holds however you're submitting, whether it's as an individual, as a group, or as an MVP. Janice asks, and thanks, boy, these are great questions. Thanks everyone for your participation. Regarding the patient electronic access measure, oh no, I think I covered that one already. Oh, I may be to the end of the questions just in the nick of time. So I hope I got to your question. If I didn't, don't hesitate to submit it by email or even onto our chat function. And stay tuned. We'll be back with the final rule when it's released. My next task will be to get my comments together and submit to Medicare, and also take some of these pre-warnings as a set of development priorities for my team to make sure we're serving you well as these rules come out, and stay right on top of it for you. So thank you very much and good afternoon.
Okay, thank you everyone. Please do reach out if you have questions that didn't get answered, and stay tuned for our updates on the 2022 final rule.